Okay, so the pronunciation in Polish is Roschewski, but you can imagine as a physician I answer to many things, Dr. Mark being the most common one. But so I think what I'm going to try to do today is be a little more focused on how we're thinking about assays for measurable residual disease, minimal residual disease, circulating tumor DNA in lymphoma. And this is something that we've been working on at the NCI for a while. We take care of patients, of course, with various types of lymphoma. And I think one mistake we probably made at the beginning was to think about these assays of solving all of our problems, right? It's such a versatile analyte, we can solve all of our problems. But that got us a little less focused. And I think now some of the things I've been thinking about is how do we get a few things across the finish line? Like how do we get a few things that are established, are being used, and then there's a potential trickle-down effect once these things get out to clinicians to be used across the various time points in treatment. So I'm going to do that today, and I'm going to focus on diffuse large B-cell lymphoma. So this particular talk is sponsored by Foresight Diagnostics, so that's important, but certainly these are my slides and my views. So I sort of structured this in three different ways. I first want to sort of stay high level and think about precision medicine in lymphoma as a whole. And then let's try to figure out what exactly are the problems we can solve with the current assays. And then I'll show you some data and then also some things that are actually happening right now in lymphoma that I think are very exciting. So I mean, the first question of why we even think about this group probably doesn't need to be sold on this, but this is what we do. We define diseases differently, right? Everyone's discussing it this way. We think about these diseases differently than just things we see underneath the slides. We are essentially in the molecular era of thinking about diseases. And so because of that, all of these various components are critical to get that information to the clinician and the patient. And I'm going to focus my attention on this talk on sort of where we are in lymphoma with assay design and specifically what we've learned with our research. So one of the things that happens when you take care of these patients with aggressive lymphoma is you're trying to cure them. And the way we define that cure, we call it remission. And this is what's happening in practice. We give patients therapy, what we think is the best therapy, and we can cure probably 3/4 of these patients. And what we're doing is we're assessing their response to treatment with PET scans. Okay, so PET scans are extremely important in the way we think about remission, but what happens is maybe about 3/4 of these patients will achieve a remission as defined by the Deauville score. And what do we do with those patients? We try not to do anything else, but still 15 or 20% of these patients will ultimately relapse. So even though you tell your patient that they're in remission, we know that a significant minority of these patients will actually experience relapse at some point in the near future. So it's not sensitive enough to pick up the early signs of relapse. But the other problem also exists. When we have a patient that does not achieve remission with our PET scans, we call this less than a complete response, defined by Deauville 4 or 5. This happens in maybe 1/4 of the patients. That's not a good enough test. We actually need confirmatory tests, and the guidelines tell us that we need to either do another tissue biopsy or follow them with this PET scan, because a single PET scan doesn't give us the information we need, which is to say, am I truly in remission, yes or no? And so this becomes something where you do this confirmatory test. You need it to be negative before you can truly think that you're in remission and go back to surveillance. And you really should be doing these tests, these additional procedures, before you move on to salvage therapy. And I'm going to come back to this concept in the future, because this takes additional time, right? This takes not only time, but resources. And when you're in a situation where you're trying to cure your patient and you want to move on quickly to salvage therapy, the last thing you want to do is do unnecessary tests. Okay, so conceptually speaking, if we think about how we treat our patients with aggressive lymphoma, we treat them in cycles. We give them first-line therapy, but the only goal in large cell lymphoma is how do we improve the cure rate, right? So we're not trying to simply extend the progression-free survival curves. We're trying to improve the number of patients, the proportion of patients that actually achieve a cure. And because of that, there's multiple different strategies to improve the way we do it. Certainly we could use a better therapy, that would be great, but there's different strategies such as risk-adapted paradigms. We've seen ongoing trials that are doing this, trying to identify either high or low-risk patients, treat them differently. There's response-adapted paradigms, which are to say, okay, let's not decide ahead of time. Let's wait until we get into the middle of therapy, and then we can alter our therapy based on how well the patient responded. This, of course, has been effective in acute leukemias. And then what I'll touch on a little bit is not happening in large cell lymphoma. Can we conceive of a world in which we're actually doing early salvage paradigms? Can we conceive of a world in which we're treating patients that don't actually have anything on a radiographic scan? And so what do you need? Well, you need to have a sharp enough tool. So one of the limitations here for all of these things, so these paradigms have been tested across different clinical trials in lymphoma, but we really haven't had sharp enough tools to tell us which patients should have these things. And what I'm going to get at a little bit more is that one of the things that these MRD tests can offer us in lymphoma is selecting the right timing for our patients. So that is the theme that we've heard with multiple speakers now in precision medicine, the right therapy, right time, right patient. Probably the circulating tumor DNA assays that we have now are best served here at trying to help us understand the right time. Now, there are certainly applications of circulating tumor DNA that could potentially select our patients. I think that's true, but I think in the spirit of focusing on what I think are the lowest hanging fruit, I'm going to focus on the right time. And I think of these assays as a precision medicine tool. So, in order to improve outcomes or establish clinical utility, as was said earlier, there has to be a problem that can be solved. Well, the first thing I sort of touched on already is the limitations of what we do now. So if what we did now was perfect, then we wouldn't be able to improve outcomes. But the problem we have is that even though PET scans are essential to understanding how much disease we have, they have fundamental limitations. Fundamental meaning no matter how good our PET scans get, we can't improve them to the point where they overcome this problem. And the problems I list here are, a 1 centimeter tumor is 1 billion cancer cells. So these imaging scans are not going to be able to detect minimal residual disease. That's not possible. And at least the ones we've developed to this point really don't have enough specificity to actually tell us that the patient has lymphoma. It can tell us that there is a problem. It doesn't tell us necessarily that that's lymphoma. And another thing that we don't talk about as frequently, but is changing in the way we apply medicine, is we don't have good large tissue biopsies like we used to. The practice of medicine has evolved. We now have smaller and smaller tissue biopsies. There are procedural risks. There are situations in which we can't actually get a tissue biopsy. There's notable inaccessible sites, such as deep in the abdomen or in the CNS. And this becomes a problem when we're trying to talk about biomarkers or these types of things, but we can't actually get the tissue. That's the only way we can get it. In lymphoma, it doesn't circulate in the blood very often. At least the cancer cells don't. So we're stuck trying to get tissue biopsies in places that may not be imminently accessible, or using biopsies that don't have enough tissue to get to ask the questions we want to ask. Okay, so let me try to prove this point to you a little bit. So this is a large analysis of the way end of therapy PET scans can function. All right, so this is 1,000 patients treated on the Goya study with diffuse large B-cell lymphoma. And what these curves are showing you, the top blue curve there is patients that achieved complete response. And you can see that there's definitely a difference in prognosis. End of therapy PET scans are prognostic. That's true, for sure. The problem is up to 20% of these patients had a PFS event that were in remission within 2.5 years at the end of therapy. But the other problem was even more dramatic. If you look at the red curve, you can see that that's worse, but not all those patients that have a positive PET scan progress. In fact, it's fewer than 50% of those patients either had a progression event or died at 2.5 years. So in other words, a positive PET scan at the end of therapy is a flip of the coin to tell us whether or not that patient actually has active lymphoma. So what can we do about that? Or what are the ways we can solve these problems? So in large cell lymphoma, the tumor cells do not circulate in most cases. So this is where there's a little bit of a departure from the way we've thought about other hematologic diseases such as myeloma or leukemia. What we're talking about is sampling from the peripheral blood, but we're not sampling the tumor cells specifically. We're sampling the free-floating DNA, and we have to be able to discriminate that from the free-floating DNA that's not from the tumor, right? So the assay's fundamental thing it must do is tell us which of this is circulating tumor DNA, not the cell-free DNA that we get under normal processes. So it has to be sensitive and it has to be specific, but it can give us a real-time readout. So these are things that we can get. We can see the kinetics during therapy, and we can get them quickly, and with basically very limited invasiveness. And there are ways of using this to get genotypic information. I'm not going to focus on that today, but certainly that's another chapter in this long story as well. Okay, but what are the challenges here? So one of the things that's become evident to us as we study this is when we want to look at circulating tumor DNA, it's really easy at the beginning when there's a lot of circulating tumor DNA. But when we're trying to find a needle in a haystack at the end of therapy, when we're trying to determine if a patient is truly in remission, that's where the assay sensitivity really matters, and it's not going to be the same across all assays. At the end of therapy, you should have very little circulating tumor DNA, so that ability to discriminate there becomes critical. And that's what's highlighted in both those first two points. The other thing is that we don't do this. We don't check blood right now to determine if our patient's in remission. We do PET scans. We're so used to it. It's part of our practice of medicine. We've been doing it for 20 years. We get the result. We can look at it. We know what it means. It is not yet in our vernacular, at least in lymphoma, to be ordering blood tests, waiting for a result to come back to determine if our patient is in remission. And it currently requires a centralized testing model. So these are the challenges that I think we can overcome, but they're certainly there, and we should be discussing them up front. Okay, so we've been studying these types of assays for about 10 years at the NCI across large cell lymphoma. And what became evident to us is what happens when the assay itself lacks sufficient analytical sensitivity. So what happens is when you're tracking a small number of mutations or a smaller number of reporters, such as just a B-cell receptor assay, what you can see here in the bar graph on the right is that these B-cell receptor assays, if you wanted to ask a question of, can I tell if a patient's in remission from a single blood test, you really couldn't do it because the assay didn't have sufficient sensitivity. And even when, SNP, single nucleotide variant-based assays looking at multiple reporters, even then, the sensitivity, the clinical sensitivity to actually detect who still needs treatment, who is not in remission, was still less than 50%. And this is where I think the opportunity comes with some of these newer assays. So one of the things we've been studying more recently in our clinical trials is something called phased-seq. So this is where I believe the opportunity lies. And what this is instead of looking at a single reporter or cis or trans, it's looking for the phased variants, which are a natural product of AID and somatic hypermutation in B-cell lymphomas and other cancers. These phased variants are now different somatic mutations on the same cell-free DNA molecule. So what's happening then is by statistical means, you can actually show that if you can find these phased variants, the likelihood that that's not from the tumor becomes vanishingly low. Because of the fact you're seeing multiple different phase variants that are coming from the tumor. And that is the technological advance that is allowing us, in my opinion, to think about how we're going to use these at the end of therapy to have a better definition of remission. And this is data that's sort of showing you that if this was presented by Jordan Goldstein at last ASH, and this was a pooled analysis. We have 6 different clinical trials in which we've been pooling our data to see, how does the performance of phase-seq work in this situation at various time points. And his question was a little more straightforward. He said, well, what is it, how important is it to get to 1 in a million cancer cell equivalents? Like, in this case, what's the difference between 1 times 10 to the negative 4th, 1 times 10 to the negative 5th, 1 times 10 to the negative 6th? And what you can see here is if you have an assay that can go with that level of analytical sensitivity, this translates to an improved clinical sensitivity all the way up close to 90, a little bit over 90%. So what that's saying is that if the assay is sensitive enough, at a single time point, we can identify up to 90 to 95% of patients who will ultimately progress with just one blood test. And I'll show you some of the data supporting that statement. Here is specifically what he was looking at different time points with this same assay. So before you start treatment, you got all this circulating tumor DNA. You don't need that level of analytical sensitivity to ask the questions you want to ask. You can see that pretty much all the different limits of detection can perform equally well at baseline. But once you start killing the tumor, once you get in the middle of therapy, and this is showing you after 1 cycle, after 2 cycle, you can see this purple graph become more critical, because at that point, that's when the analytical sensitivity becomes so important if you're going to try to predict future events. And so it's rather striking and obvious at the end of therapy, at the end of planned therapy, that the assay must perform at least for 1 times 10 to the negative 6 to achieve this clinical sensitivity we've been talking about, which is to say over 90% predictive. Okay, so where did this come from? So this is a collaboration we've been doing with researchers out of Stanford for about 4 or 5 years. And the first question they asked is, well, how does this phase-seq compare to other assays that we've used? That's what this Kaplan-Meier on the left is showing you. So that's 52 patients that tested negative or were undetectable by CAP-seq in this case. And they were asking, well, can you risk stratify further with phase-seq? And then that curve is showing you that you can. So you can distinguish patients that tested negative or undetectable by another assay. If you use a more sensitive assay, you can actually start separating these curves more easily. This is showing also data at the end of therapy. In the middle, what that's showing you is CAP-seq, in this case, does pretty well, right? So it's prognostic, just like PET scan. It is prognostic, but it's not as prognostic as, in this case, phase-seq. Once you start getting this analytical sensitivity that's greater, you can start showing patients that top curve, that blue curve on the right, that's showing you patients that have virtually no risk of relapse with a single blood test. Okay, so I'm going to show you a little bit more data to support these concepts and why I'm so bullish on the performance of these newer assays. So there are a few other things that I think have been established in large cell lymphoma with circulating tumor DNA assays, not specific to any one particular one, which is to say we can ask questions at different times during therapy, and this is data showing you how do these tests perform at the beginning of therapy. Okay, so this is probably a fundamental lesson that we've learned in large cell lymphoma, probably also Hodgkin lymphoma, is that the levels of circulating tumor DNA at baseline are prognostic. Now you might say, well, that's rather intuitive. It's a marker of tumor burden, right? Well, it is, but it also shows us other things, because on the multivariate analysis you can see on the right, it's not simply a measure of total metabolic tumor volume. In fact, TMTV, which stands for that, the total metabolic tumor volume from PET scans, was not as prognostic as the pretreatment levels of circulating tumor DNA. So what is in the circulating tumor DNA is showing us not just a measure of tumor volume, it also has other biological processes that are part of that, part of those levels. Another concept that I think will stand hold in the treatment of aggressive lymphomas is that these real-time kinetics show us a very rapid readout. So we saw this early on when we studied immunoglobulin receptor assays. What we saw was that when you give chemotherapy, you get a rapid readout extremely quickly. And that's what these data are showing you with phase-seq. What I want to highlight is these median bars here. You can see that the pretreatment level is quite high, of course, because most of these patients had advanced disease. And you can see after just 1 cycle, it starts rapidly dropping, and 2 cycles, it rapidly drops, but then it kind of levels off. And so what is true and probably makes a lot of sense is that what happens when we give at least chemotherapy is these changes, these tumor kill happens very rapidly, and the resistance stays. And so you can actually get these readouts pretty quickly. You don't even necessarily have to wait until the end of 6 cycles. You may not want to wait until the end of 6 cycles to declare that your therapy is not working. These blood tests give us this readout. We have other data that I'm not showing you that you can get prognostic information after only 7 days of therapy, actually. So I think this is still being teased out about how quickly can you actually get a readout of whether or not your patient's responding or not. And so this is sort of building on what we saw with other assays. This is showing you performance of the phase-seq, and this is showing you that not only can you get an early readout of tumor kinetics, that's actually prognostic. So the same thing that was done when we used PET scans, and this is getting sort of at this response-adaptive paradigms that we've been talking about. You can see that undetectable MRD, undetectable ctDNA, after just 2 cycles of R-CHOP, is prognostic, and most of the patients on the top curve actually are going to do quite well. They should continue therapy, and the other patients, maybe we could conceive of thinking about them in a different way. That's been shown now also to be true not just in the upfront therapy of large cell lymphoma, but the data on the right is showing that an early readout can be had also in the relapse setting after the delivery of Lysocell, of course, which is a CAR-19 product. So again, highlighting this idea that the readout that we might have to wait for end of therapy scans, we can actually get this information much quicker with the use of these ctDNA assays. Okay, so within the context of that pooled data that I talked about, we have our own clinical trial at the NCI, and we wanted to have a little bit more granular look of specifically how do these assays compare to PET scans. And so what we did is we had, this was 54 patients. It's an ongoing trial, so we're not quite done with the trial. And we asked the question of, how does the end of therapy PET scan compare? And what we did is we had the PET scans read blinded by nuclear medicine physicians. So if you're a physician taking care of these patients, you know that we go read our PET scans ourselves, and we kind of try to figure out what it means, and we make a decision. But in this case, we wanted them read blindly. So we had the nuclear medicine physicians, 2 of them, read these end of therapy PET scans blinded. And you can see that this indeed was prognostic. That's on the left. So if you achieved a negative PET scan, it was much better than if you had PET positivity as read blinded by those nuclear medicine radiologists. But it was much better if you applied, in this case, phase-seq. By the end of therapy ctDNA, the top curve here, the 2-year PFS, was almost 100% in patients that tested negative or had undetectable ctDNA. Again, highlighting that this is probably a better discriminatory test than we can get with PET scans alone. So the question here is, how does it compare in that greater pooled analysis that I talked about? So Brian Swarter also asked this question, and he said, what is the negative predictive value and the positive predictive value of end of therapy PET scans versus end of therapy ctDNA? That's shown on the bar graph on the bottom. And you can see that in the greater, well, not just in our clinical trial, but in this greater pooled analysis, you can see that that the end of therapy PET scans just did not perform as well as the end of therapy ctDNA. And on the Kaplan-Meier curve on the right, we're seeing this situation where these are 30 different cases with discordance. So this is saying the PET scan is telling you one thing, the ctDNA is telling you something else, which is closer to absolute truth. And it looks like in that data set and what we've seen so far is in most cases, we're seeing that the circulating tumor DNA is giving us the more accurate readout at the end of therapy. So one of the first slides I showed you is I said that right now we don't use a single test to figure out if a patient is in remission. We get our PET scan and then we have to do additional procedures. That's baked into the guidelines. So that's what's listed here in the NCCN guidelines. So when we first applied PET scans to the treatment of large cell lymphoma, the reason they became part of the response criteria is because they were better than CAT scans. Okay? There weren't randomized trials that showed that was that improved outcomes. They were just better than CAT scans. But even in the text, if you read those papers, they tell us, but hold on, if you're going to treat your patient further, you better adjudicate that. You better make sure that that's actually disease, either with a follow-up scan or a tissue biopsy, before you just move on to salvage therapy. That's a current paradigm that I talked about. But how often does this happen? How often are we actually getting these tissue biopsies? When we get these tissue biopsies, are they useful? Are they unnecessary? Are they delaying us taking patients that need salvage therapy sooner? These are pieces of information we actually don't have. We don't have data sets on this, on how often are physicians actually doing tissue biopsies before they take a patient onto salvage therapy. And the obvious question is, well, could a blood test, such as an MRD test, help to adjudicate that? Can we get to a point where we look at our PET scan and we say, you know what, I'm not sure, I want to get another blood test, that's easier than a tissue biopsy, to actually figure out if the patient's in remission or not. So we asked this question and presented this data last year. We said, okay, going back to that study I told you about that we have at the NCI, let's look at those patients that had a PET scan and let's see what we did. So these are patients that had already gone through therapy. We had already decided what to do based on their PET scan. And you can see that 14 of them had a positive PET scan as determined by those 2 nuclear medicine physicians that were blinded. And of those 14 cases, 9 times we did an additional procedure, either a follow-up PET scan or a biopsy. I guess that means 5 times we were so convinced it wasn't even positive, we didn't even feel the need to do an additional test. But most of those were not necessary. Most of those situations, we did not identify lymphoma. So that is suggestive that many of these procedures we were doing are just adding additional cost and time, but they actually aren't showing us lymphoma. We also then had our phase-seq results, and what you can see here is that 7 of those cases actually were MRD positive, and 2 of those patients have progressed. This is an ongoing study, so some of them we're still waiting to see what happens, and 1 patient died of AML. So in that situation, I'm going to come back to this, that test alone may not be enough, a positive test in the situation of a PET positivity. These positive tests don't always result in patients progressing, at least in our data set. But what has come out of this data set is that none of the patients that have tested negative have actually progressed. So whether they were PET positive or PET negative, all the patients in this study, none of them that had a negative MRD test have progressed. And 4 of these patients down below that were negative on PET scan, 4 of those patients tested positive for MRD. So the summary from that particular one is that most of the time when we're doing these tests, they become unnecessary, 8 of 9 in our case. Most of the time, these patients that have a positive PET scan by these criteria do not progress, and most patients that have undetectable MRD have a very low risk of ever progressing, to include years in the future. Okay, so that's some of the data that I'm most excited about, and some of these are going to be published in the near future. But the question then becomes, well, what are we going to do with it? Maybe you're skeptical. You should be. We should all be skeptical. So how are we going to think about this as far as designing trials? And there are some ongoing efforts happening now. So going back to the sort of anchor slide about we want to cure these patients, and we're going to use a bunch of different designs. All of these things are actually happening right now. So risk-adapted designs, response-adapted designs, and even early salvage designs are actually in development and either open or will open soon now. And we will have to wait for those results to actually prove the clinical utility. But let's go into it a little bit more. So we've had other biomarkers, right? We've done these tests when we've decided to try to determine in the middle of therapy, can we alter it? It hasn't been successful in large cell lymphoma. My opinion is that's because we haven't had good enough drugs. So in situations where we've altered the therapy, a lot of times even the PET scan was able to discriminate the risk. It's just if you don't have a better therapy to switch the patient to, it's going to be difficult. And most of the studies that have been successful have actually been stepped down. And what I mean by that is giving frontline therapy and then doing a test in the middle of therapy to see if it's going in the right direction. We can think of this as the way we treat CML or other situations where, okay, if you hit this benchmark, you're going in the right direction, you can go ahead and continue therapy or even abbreviate it further. So we've done this in Hodgkin lymphoma, we've done this in HIV-related lymphomas at NCI, and most trials actually that give less therapy are successful, believe it or not. Whereas the patient that has a lack of a benchmark, then those patients get taken off therapy. This maybe isn't as interesting to give less therapy, but certainly this is important to patients and to healthcare costs because of the toxicities of our treatment. This is an example of an ongoing trial that is not exactly using response adapted the way we're talking about it, but an effort to move away from chemotherapy. So Jason Weston at MD Anderson has been developing this platform where he's using targeted agents first before patients ever get chemotherapy. Okay, he's published this before where he gave target agents and then continued it with chemotherapy, showing that you can get responses. Maybe it's conceptually similar to sort of neoadjuvant therapy that we think of in solid tumors. And what his latest iteration is, which we should see data on here at ASH, is what about patients that get a complete response to the targeted therapy? In his last cohort here, cohort C, those patients are going to be treated without any chemotherapy whatsoever. So he is not using, in this case, circulating tumor DNA to make that decision. He's using PET scans, but he is using circulating tumor DNA to help understand how that would have performed in the context of such a trial. And I think we are moving in this direction in large cell lymphoma, where we're going to be thinking about, other trials that are trying to move away from chemotherapy. And we need a very sharp tool to feel confident that we can actually move off of chemotherapy when the goal is so high, cure or not. Then the other clinical trial design that we've talked about many different times is this step up, right? So this is saying, well, okay, we've got patients, we don't know if this therapy is going to cure them, but can we figure out before they're done with 6 cycles of therapy that we actually need to switch? So this is an example of a study design. You can give the upfront therapy. If you hit the major molecular response, you're good. Keep going in that direction. You're right. You're going in the correct direction. But if you don't hit that major molecular response, if you remember those curves, you probably only have about a 40% chance of being cured. That becomes a testable hypothesis. Can I switch therapy and improve outcomes? That is something we could show clinical utility, yes or not. Relatively straightforward because we can get the readout and then we can test the alternative therapy. It's my belief we now have the right alternative therapies to ask these questions. I don't think that was true 10 years ago, but at least in large cell lymphoma now, we've got some really good drugs and really good questions that could be asked to try to actually achieve this goal. And sort of the last frontier would be and this is something we don't do in large cell lymphoma, we do this in acute leukemias, is can we actually think about treating patients that don't have anything on PET scan? So here is an example of such a thought process. You give frontline therapy. This is going back to a previous slide. We're showing you that 75% of these patients are in remission. You want to make sure, so you do your blood test, and you do your blood test just to make sure that patient doesn't need any additional surveillance. I don't need to do CAT scans, nothing. That patient's probably cured. If, on the other hand, it's positive, that also becomes a testable hypothesis, right? So we don't treat patients on the basis of molecular disease. That is a completely new horizon. We don't do that in large cell lymphoma. We don't think about treating MRD in large cell lymphoma. We don't think about treating anything that's cell-free DNA. It's all tumor cells. But there are examples of ongoing trials, and I think there's other trials that are being planned in this description of MRD erasers that are now possible when you have a good enough tool. Whereas other patients that meet this criteria for a positive response, you might think, well, sure, they're positive. They should go on and get salvage therapy. But I already showed you earlier that only half those patients actually have disease. I don't want to be whisking them off to second-line therapy quickly just because they have a positive PET scan. Can we imagine a world in which we're using blood tests to help adjudicate that, to just help us feel better? Whether or not we need to follow that up with a tissue biopsy or not, we could sort out later. I don't think this would necessarily need a clinical trial to prove. This is the practice of medicine, right? This is what we did with PET scans. We learned how to use these tests as they became more available to us. It would be difficult to show that in a clinical trial or even design a clinical trial on how to adjudicate it on the basis of a blood test alone. But that is what happens when things become available to us, is we learn how to use them over time or use real-world data to try to help us understand how these tests can sort out which patients are truly in remission and which are not. In the last few slides, I will just say that since I focus exclusively on lymphoma, I do feel behind the other tumors. Even in heme malignancies, I think we're farther behind, but there have been efforts placed to discuss not only in lymphoma, but even solid tumors, how do we put this into the response criteria? It becomes a little bit of a circular argument because we say, well, we can't put it in the response criteria until we have enough data. And I say, well, we're not going to get enough data until we have it in the response criteria and everybody does it. And this kind of goes round and round and round. There have been other efforts in this case this publication to think about, well, could you have sort of a alternative or complementary response criteria? We've done this with PET scans. Can we just think about these differently instead of replacing anything? We're just trying to make our response criteria better. But our response criteria are supposed to tell us who's in remission, and I'm hopeful that you agree with me what we do now in lymphoma doesn't do that. This is an example of the ALPHA3 study. If you're not familiar with it, what it's asking is, well, what do we do with these patients on the red curve? Okay, it's not useful for us just to tell someone, well, you're going to relapse. It'd be nice to do something. It's not proven yet in large cell lymphoma, even though it's intuitive, that earlier treatment would improve outcomes. We do know that certain things like total tumor burden is prognostic in the treatment of patients with CAR T cells. So it's intuitive to think, well, what if you came in this case, this is an allogeneic CAR T cell product, and you come in and you treat these patients that are MRD positive, can you actually erase that MRD? Can you potentially improve outcomes? These are questions that are being asked right now. And I think others have touched on this, but just as a final note, it was pointed out the recent ODAC meeting in myeloma, I think the end goal for people that want to develop drugs or regimens is, getting this readout earlier. And even in curative diseases, waiting for overall survival is certainly not feasible. It's a product of success, right? As our treatments get better, we need to have a better and earlier readout to understand what's actually going to be better for our patients instead of waiting for survival in every case. And so to that last point, and thinking about endpoints, this is a thought process that's generated by Ash Alizadeh in his lab is, can we imagine a world in which we're using all of these things together? So instead of replacing progression and death, which of course are critical, can we add in molecular relapse as an event or as a modification of progression? If this is the disease, if my assay is so sensitive or so specific that it's truly the disease, then truly the disease is not a biomarker. Truly the disease is a measurement of disease. If that's the case, and we can measure it in the blood, then this is data showing like this is how much earlier you could get such a readout based on the data we have if you considered that molecular relapse a true progression event. Just sort of like getting us thinking about, well, how much faster could we actually get the readout? It's not just simply faster, it's months faster in these diseases because, of course, they're aggressive, and so when they relapse quickly, and almost always it comes back in the blood first. And then the last slide is to say, well, I focus on lymphoma. That's the only thing I focus on. But the things we're talking about here, the landmark time points, they're not unique to lymphoma. This is just simply how we're thinking about it. And you can draw parallels to the way people think about, solid tumors in which there's a surgical component or adjuvant chemotherapy. All of these things are similar in concept, in which the landmark time point, you're going to ask different questions. The assay might need to behave very differently in different time points depending on the specific question being asked. And with that, well, these conclusion slides are pretty self-explanatory, but I want to leave some time to answer any of your questions. Thank you.
Hi, I know I introduced you, but I'll ask you a question as well. Should we still be doing CT PET in the context of your marker? I wonder if you've modeled out whether you just omit that and see whether you can actually drive therapeutic decisions.
Yeah, so I think right now, yes, because the PET scans show additional things that don't come out. So the blood tests are super specific for lymphoma, but these patients have other things that occur. So, one of the things that came out in our data set is a lot of times these PET scans are showing you another cancer. Or, so that's part of the reason they're so prognostic, is it's showing you bad things that you want to know. It's just not specific enough for lymphoma that in my view, you should take a patient off to salvage therapy. So I think at least right now they're complementary. And I wouldn't want to replace PET scans. PET scans have additional advantages. I know where the problem is. I can think about, so at least right now, in my view, no.
Great talk. Around 10 years ago, I think Luis Diaz showed in colorectal cancer, if I remember correctly, that if you don't see circulating DNA, you can pretty much be sure for that solid cancer that it's not going to come back.
Yep.
Is that true also for lymphoma? Have you done the longitudinal studies to kind of demonstrate that?
It's close. And we're putting this data together now. Right now, the negative predictive value is not 100%. There are a couple of patients that have, there's one patient I know who relapsed in her brain 18 months later, and she was undetectable. That would be a tough thing to think you're going to pick that up. The other problem with some of this, when you use PFS on such an analysis, is sometimes people get treatment on the basis of PET scans. And so if we call that positive PET scan a P, but they actually don't have any disease, the way we put the data together, we have to call that an event. So there are examples of situations in which patients will relapse. It's, at least right now, extremely uncommon. That, to me, is the most actionable thing. If I had it in my clinic today, I would say your risk of relapse is astonishingly low, and I don't think I have to do anything else. It's not zero.